Good afternoon, and thank you for joining us for today's webinar, Update on RadSite Standards for Advanced Diagnostic Imaging. Before we begin, I'd like to go over a few housekeeping items. Today's webinar will be recorded and available through our website. To minimize noise and distraction, all attendees' mics have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using your Q&A box. We will do our best to address all questions and comments at the end. I will now turn the presentation over to our moderator, Mark Casner, RadSite's Accreditation Committee Chair.
And good afternoon, everyone, and welcome to our spring webinar. I'm going to make some very brief introductions of my esteemed colleagues. First, Dr. Eliot Siegel, an internationally renowned radiologist. Eliot's worn many hats for us at RadSite and currently chairs our standards committee. We have Dr. Phillip Patton, who is our lead physicist. He has been with the organization, I think, at least a dozen years, and will speak to us about physics issues. And finally, Julie Irons. Julia heads up our accreditation team and has done that for probably at least a dozen years or so as well. So welcome to all of you, and let's go ahead and get started. Quick agenda items here. Obviously, we want to go over the standards. We want to talk about the accreditation review process, and Julie will spend more than a few minutes talking about that. Our portal and IT issues, some RadSite highlights, and then finally, I'll close with some future webinars as well. So if we talk about the accreditation programs that RadSite offers today, we have 5 already in place regarding CT, MR, Nuke Med, Dental Cone Beam CT, Medical Cone Beam CT, and stay tuned this summer. We'll have remote scanning operation standards as well. We have a future webinar on that. We'll talk about that at the end of the program. As you can see, we have a number of standards here. We're not going to go through all of them. We would probably need a week to go through all of them, but just to give you a sense of how the exact number of standards that we have in place today. Both Eliot and Phil will be talking more specifically about those standards updates as we move through the show. So I'm going to turn it over to Dr. Siegel for a moment to talk about our professional staff.
Thanks, Mark. Appreciate it. So the professional staff is clearly really important to any accreditation organization. And as time has gone on, we've refined our definitions and our expectations for a variety of different professional staff and requirements as part of the submission for accreditation process for these as well. And so the standard 3.3 addresses the clinical leadership responsibilities, and the 2 specific professional roles that are specified are the medical and clinical director, which would be the clinician that would have overall responsibility for the imaging program. And in addition to that, then there is the concept of the supervising physician and practitioner. And so that would be the person who is a clinician who is responsible for supervising any individual examination. And so if the technologist has a particular question about an examination that's about to be performed, or as it's the study's being acquired, or after the acquisition, then that would be the person that would be responsible. And so on any given day, it may really depend on the type of study that's being done as far as who that supervising physician is. And that is as opposed to what is specified in standard 3.4, the interpreting physician practitioner, who is the person that is actually going to be interpreting or reading the examination. And so the person who is responsible as the study is being done is often, and probably typically, the person who would interpret the study, but not always. And so it may be that studies are being interpreted later in the day or the next day, and it could be by a different specialist or subspecialist, but often the supervising physician turns out to be the interpreting physician as well. And so standard 3.4 talks about the interpreting physician. And then getting on to the technologists, we specify that in standard 3.5, looking at various roles of technologists. And so one of the things that has made the technologist role something that we have wanted to address is the emerging way in which technologists, to a significant extent due to the shortage of technologists, are essentially looking at creative solutions to maintaining efficiency and maintaining the ability to continue to keep up with the volume. And so one of the interesting developments has been in-suite assistance, where we have technologists who have people who are helping them out as they're doing the scanning. And as Mark mentioned, we've also looked at remote scanning, and an increasing number of outpatient imaging practices and some inpatient are actually doing remote scanning, which really will lead to a separate standard for remote scanning. But as we're looking at imaging technologists, we have a variety of different ones. We have what we refer to as the scanning technologist, and a remote technologist, and then an in-suite assistant. And those roles can be whether or not a patient is going to be scanned by a remote scanning technologist or whether it's in room. In both cases, one could have an in-suite assistant. And so understanding and defining some of those roles has been part of the emerging standards that we have been discussing in our standards committee. And then under standard 3.5.3, we've discussed additional MRI technologist responsibilities, which are continuing to evolve also, and particularly as we're looking at safety issues. Standard 3.6 addresses the position of an imaging manager, which would typically be a more administrative position, although that could be a technologist as well. And there could certainly be overlap in some of these. What's really critically important, of course, is the medical physicist's role, which is critical. And Dr. Patton will be discussing that in more detail, which is standard 3.7. And then there's also the role of the imaging or radiation safety officer, which is addressed in standard 3.8.
So Eliot, before we move on to the specialty area updates, can you help us understand what process do we go through in terms of updating any of these standards? Can you give us a process orientation in terms of we identify these standards and they need to be looked at because the environment has changed? Maybe you could spend a few minutes talking about the process of the standards committee, how often you meet, et cetera.
Yeah, Mark, that's a great question. So the standards committee has been meeting much more frequently recently due to so many of the different changes that are happening in outpatient imaging facilities. We talked about remote scanning and talked about increasing concerns about safety issues, particularly MR safety, and so many other things are continuing to be issues. So, as we do audits at RadSite, we identify issues that may be of concern. We have questions that come in from our various sites. You are keeping up with the news and emerging standards that are coming out from organizations such as the American College of Radiology. And so as these issues come up and are brought to our attention, and they're brought to the attention of committee members, these are issues that we discuss at the staff level, and then we have an agenda for each one of the standards committee meetings. And the standards committee is made up of a broad variety of different representatives, including radiologists, technologists, administrative folks, even industry folks. And that particular group discusses many of these issues that have come up, looks at the current standards and looks at how we can, A, make sure that the standards are consistent across multiple different modalities, but also looks at how can we take this evolving set of expectations at outpatient facilities as they are struggling to meet the demands as volume is increasing, complexity is increasing, and as new ideas are being introduced, and discuss those at the standards committee meeting. You asked how often does the committee meet, and sometimes it has met as infrequently as every 2 or 3 months, but sometimes it's met as frequently as every 3 weeks or so, depending on how many issues there are that are going on, and depending on how we're making modifications and changing. We also have a quarterly meeting with CMS where we have the opportunity to discuss the things that we're doing with the other accreditation organizations. And those discussions also lead to ideas that we have for the standards committee. So, there is that process. The standards committee then debates, and sometimes there's fairly vigorous debate about different ideas and, specific requirements for amount of training, requirements for amount of experience, requirements for things that are brand new, like the remote scanning requirements. And sometimes, and actually in many cases, RadSite has sort of led the way, looking at what's happening in contemporary practice and looking at how one might be able to implement some of the new trends and how they relate to standards. Even new technologies such as low field strength MRI comes up for discussion in the standards committee meeting. And in addition to the standards coming out according to what is best for each individual patient, there are also challenges associated with questions that come up from CMS and even some of the private payers that have an influence on the agenda of the things that are talked about in the standards committee. So standards committee meetings are typically an hour and a half, and the discussion tends to be, really pretty interesting and intense. It's often that we actually don't get a chance to finish the entire agenda and need to schedule a meeting a little bit sooner. So they're really interesting discussions, and I've been really pleased at how engaged the committee members that are, so varied in their experience and in their expertise contribute to those.
So Eliot, with a not so recent advent of cone beam CT, and I know we do have separate cone beam standards meetings as well, what particular challenges do you see with the standards in particular as we introduce more cone beam CT into our practices?
Yeah, it's a good question. I mean, I think one of the many challenges with cone beam CT is the way in which radiation is measured and exposures are measured are significantly different in comparison with non-cone beam, or let's call it conventional CT. The other issue is an issue from a physics perspective of determining image quality. It's relatively standard to make measurements with certain phantoms for conventional CT, but there's much less agreement with cone beam CT. In fact, much of what's done in cone beam CT by the physicists is actually utilizing the vendor's own phantoms and the vendor's own standards. And so one of the interesting comparisons between conventional CT and cone beam is that in conventional, one has physics standards that cut across all of the different CT systems. So one can compare, a brand A with brand B with brand C, all along a certain set of parameters related to contrast and resolution and a variety of other quality parameters, including noise, whereas those are not really standardized with cone beam, and to a large extent, they're self-referential in the sense that each vendor has its own set of what the parameters are and even its own phantoms and ways of scanning. And that's a fundamental difference. And so what I would really like to see as the head of the standards committee is for cone beam CT to have more of a homogeneous mechanism for measuring radiation dose, because claims for cone beam CT are pretty wide and broad, and there's not really a standard the same way there is in conventional CT. And also for image quality, I really would like to be able to compare one cone beam system versus another, which is more difficult to do than with conventional CT. And I'd like to compare cone beam with conventional. For example, for ENT imaging, people are increasingly doing cone beam scanning or for extremity imaging. And yet, how does that compare with, say, conventional CT from a radiation and quality perspective? And so those are a couple of differences. Another difference is that in so many cone beam systems, for example, dental cone beam systems, you don't have a radiologist interpreting the study. You have the subspecialist. You don't have a technologist doing the study, but you have somebody that essentially does multiple things in the dental office that, you know, serves as the technologist. And you don't typically have a radiation safety officer already designated. And so, you know, those are really important distinctions. And of course, there are regulatory distinctions from one to the other. So even though they're both producing relatively similar cross-sectional images, there are really significant differences from one to the other. And so I'm really pleased that RadSite has tackled cone beam CT, because I see cone beam CT as being much more varied with regard to patient radiation doses, and is varied as far as quality and varied as far as training of personnel. And I think the idea of having an accreditation organization be very much involved with those is really, really critically important for quality, safety, and efficacy for our patients.
Great.
Eliot, one of the things we've started doing on the physics side is we've purchased a commercial Phantom for image quality, and we've started collecting data on different CBCT vendors to see how tight we can create the standards from one vendor to the other, have a uniform standard set, like you're saying.
Yeah.
But we're in the data collection phase right now.
I'm really pleased to hear that, because that is an effort that's long overdue. And so I love the idea that your group is pioneering that, and hopefully we'll share some of those data, you know, so that we could utilize it for patients. I'm very anxiously looking forward to that. We've had the opportunity to work with some of the folks from the AAPM in physics that have given us some information, and Phil, with your expertise and advice, it's really been wonderful to be a trendsetter and to, you know, be able to try and set that. So I'm really delighted that you're essentially working on mechanisms to be able to compare one system with the other and to cut across different systems. So thanks for that update. I'm really anxious to hear how that goes, and it'll have significant implications for us setting the standards.
So before we segue completely into Dr. Patton's discussion, Eliot, maybe you want to spend a couple of minutes talking about the specialty modules. So you can see that there's a plethora of them listed here, and whether you have any additional comments on those specialty modules.
Yeah, well, if you look across the different accreditation organizations, you see a fair amount of variability in these kind of specialty or center of excellence, you know, types of modules. And you know, certainly within different specialties, such as conventional CT, you know, one has cardiac imaging, for example, which arguably and importantly requires, you know, additional training beyond what one might have to typically interpret CT studies, and may also require a higher level of standard for the equipment that we use. And similarly for MRI, and for a SPECT and PET and cone beam CT. And so because of a variety of reasons, you know, particularly due to some special requirements for interpretation skills and requirements for the systems themselves, you know, there are additional requirements for doing certain types of subspecialty studies. And so because of that, there has been the emergence, you know, driven in a number of reasons, including patient safety and efficacy, but also the payers have also required for reimbursement additional parameters for training and also for the equipment. And so, we've created sort of our own classification for these additional subspecialty modules. And so, as you would imagine, they would include cardiac for CT and MRI. Of course, for cone beam CT, in addition to dental cone beam CT, there are specialized cone beam CT systems for breast and ENT and maxillofacial and musculoskeletal imaging. And under MR, the distinction is made with functional imaging and vascular and other types. And so, each one of these modules requires submission to demonstrate to RadSite that, there is expertise both in the interpretation of studies and in the quality of the studies from a clinical and a physics perspective. And so these additional modules give us more granularity and more ability to specify and say, if you're doing cardiac imaging in PET or PET CT, for example, there are certain things that we need to understand and know about in order to be able to feel comfortable with accreditation. And so depending on what individual sites are doing, then there are also these subspecialty modules where we ask additional questions of the interpreting practitioners and also of the equipment. So I won't go through each one of these in the list, but this is essentially our own classification, which differs a little bit from the other accreditation organizations. So thanks for the opportunity to go through that. These are always being fine-tuned and in some degree of flux also. And so the latest version is what's referred to as version 3.6.
And before I let you go, I have one more question, Eliot.
Sure.
So as we talk about these specialty modules, how important is field strength for some of the MR studies or the number of slices for CT in terms of being able to adequately address whether the studies are appropriate or not?
Yeah, it's a great question, and this has been debated, so much in the imaging literature. I mean, what is the optimal field strength? Do you need a 3 Tesla or 1.5 to do advanced prostate imaging? What should be the requirements for, number of slices or number of sections for cardiac imaging with CT? What's the minimum number that should be required for even doing a CT pulmonary angiogram? What is optimal? And what we found is that a lot of debate exists about these, and so this really makes the physics portion of it so important. And we talk about field strength, but really, if we have really well-defined physics parameters, we can rely on the true experts, the physicists, with regard to what are the parameters that we should be utilizing. And for me, I think if a lower field strength MR system is able to produce images utilizing phantoms that are comparable to higher field strength systems because the imaging time is longer in a protocol, or because they're using AI, convolutional neural networks, or other advanced reconstruction techniques that are constantly emerging. From my perspective, I tend to think less of the importance of the number of slices per se in CT, or less important the actual field strength itself for MR in comparison to how these systems actually do empirically when our expert physicists end up testing them. So I'm sure Dr. Patton has some ideas also, but I really put a tremendous amount of stock myself in the testing and expertise of our physicists, rather than in just some of those parameters that are kind of touted maybe by some of the vendors. And so in my own opinion, I think that any of the payers that are specifying very specific parameters for number of slices or for field strength or for age of the equipment, for example, to me, I think if our physicists can empirically demonstrate performance, then I think that would guide me to a greater extent. I know from your perspective, leading the accreditation committee, you need to make some of those decisions about whether or not to accredit some of these systems that sort of come into the borderline of what some of the payers suggest are acceptable from a field strength perspective or slice perspective. But to me, I think our physicists really are the ones that can inform us better than any one particular number.
Great. Eliot, thank you so much. We're going to give you a breather and turn it over to a great segue into Dr. Patton.
Thanks, Mark. Great questions.
So one of the things about a physics evaluation, it's not new to us. We've been evaluating imaging systems for decades. We started with mammography, and CMS, they've actually mandated that we have some type of evaluation for the advanced protocols. The advanced modalities. And one of the things we do from the mandate from CMS is we require a third-party physics group to evaluate all the modalities that we accredit. And, we accredit CT, MR, SPEC, and PET, along with the cone beam CT units. And so the standards that are set are in standard 7.7, and they go 7.2 for CT, 7.4 for MR, and et cetera. The parameters we look for, well-established parameters. For example, for CT, we're looking at what's the high contrast spatial resolution, what's the low contrast detectability, and several other parameters. And these come about from basically experience with working with radiologists and working with service personnel from different vendors, trying to determine how do we accurately determine if that modality or that unit is performing the way it should. So the actual the requirements for the physicist to evaluate are not unique, but they're like, how accurately is the CT number for what we're reading? Are the slice thicknesses accurate? And like I said, CT number uniformity, is the image uniform? Is there a lot of noise in the image that might prohibit the radiologist from seeing what is required? Again, what's the spatial resolution? And then obviously, how well can it dictate very slight changes in contrast? So in MR, it's very similar with the parameters that obviously are appropriate for MR. So what do we do? For CT, we require phantom images to be submitted. We require an adult head, adult body, a peds head, and a peds body if you do pediatric studies. And these images have to be obtained on a phantom that we've approved. Now, we don't limit to one phantom. We actually have a couple that we approve. And from there, we evaluate and see if it meets the requirements. It's really that straightforward. The images have to agree with the physics report, and the physics report has to have all passing on it. We will not accept a physics report that has something that's failed. Even if services come back later and fix that issue, the reason to have a third party to evaluate the unit is to verify that it's performing. Just because service has said it's been fixed doesn't necessarily mean that it's actually performing. MR, we actually require 3 data sets. We require a sagittal image data set, the site T1 and the site T2. We also accept 2 additional data sets that we define actually in our standards. And that's in case you're using a site protocol that is not appropriate for a phantom. Like if you're using a propeller type of scan, several of the slices will be unusable from a phantom just by the nature of the protocol. And so we actually have some predefined protocols that you can also submit. So we'd evaluate the site, see if they pass. If they do not, then we'd move to the predefined ones that you submit. It's pretty straightforward. We've been evaluating MRI again for decades and setting up, what we consider a good functioning unit is. CMS has a pretty narrow scope of what they allow, us to look at for that. And so we adhere to that. For nuclear medicine, QC for nuclear medicine has probably been going on maybe the longest for the modalities. From the nature of having a RAM license, you have to have certain types of QC be completed. So for nuclear medicine, we're looking at uniformity. Obviously, we're looking at resolution. We're looking at for a spec acquisition. We're looking to make sure that the image quality is what it should be. You know, are we getting the right resolution there? Is it uniform? For PET, we're making sure we're getting the right SUV numbers. Again, the images are uniform. The resolution is where it needs to be. As Eliot said, for CBCT, currently we're evaluating the unit based on the the vendor's requirements. And so we look over the vendor's QC manual, we look at the images that are submitted, we look at the physics report that's submitted, and we make sure that they meet the standards. One of the updates that we're going to do is we're going to move away from that as we collect enough data and have a set standard, so all vendors will have to meet that standard. We evaluate dose for CT, and we also evaluate dose for CBCT. Currently, we're in the process of changing our standards a little bit, or actually updating our standards, I should say, and to account for some of the advances in each one of the modalities. As Eliot said, you know, MRI, they're going to super low field strengths, and they're doing post-processing, they're producing very good quality images. And so how do we adapt for that? So we're in the process of making some adjustments. But again, our standards for physics is in standard 7. It lists out all our requirements, what we look for, and what the pass-fail limits are. A few other updates.
I think one point to underscore is how dynamic this process is, and that, you know, things are changing so rapidly in diagnostic imaging, and being able to have a standards committee and accreditation committee that keep up with these changes that are happening so rapidly, whether it's cone beam CT, ultra low field strength, MR, you know, new safety requirements, extensions of applications for cone beam CT, and, you know, new applications for a CT and PET. All of those are happening so rapidly that you really need a very dynamic process for a standards and accreditation committee to be able to keep up with this.
Yeah, that's exactly right, Eliot. And one of the things that we really are starting to focus on is MR safety. With the large number of MR units out there, some being in large hospitals, some being in standalone clinics that only have MRI, the safety practices vary greatly. And so we're looking at setting up some type of standards. So if they're coming through RadSite for accreditation, that they have to meet. And that's, I mean, I'm sure people have seen it in the news where a wheelchair's got sucked into a magnet, or a patient had some type of metal on them. So uniformly, patients are not screened. Uniformly, they're not utilizing MRI safe equipment near the magnet. And so we think that's an approach we can take, and to set a standard on that so we can improve the patient safety in that area.
Yeah, and I think that highlights the fact that an accreditation organization should not just be a gatekeeper for whether or not a particular machine or facility qualifies, but there's an ongoing education process that's really important. For example, when, you know, we receive a report from one of the sites about a near miss, you know, with regard to an MR safety issue, being able to come out, do an audit, be able to make advice, suggestions, and then follow up, you know, are really part of a continuing education process. And so, you know, in my own opinion, I think one really important role for accreditation organizations is not only keeping up with what's new, but also continuing to educate the sites and continuing to make sure that there are processes that each one of the imaging centers or imaging networks end up doing to make sure that they internally are keeping up with what's new, and, you know, maintaining as safe an environment as possible also. So to me, that's one of the more interesting roles of an accreditation organization, is that continuous education and training.
And I think it's a super valuable role, because, you know, I believe that these facilities want to do the right thing. They want to do what's best for their patients.
Yeah.
And sometimes they don't know exactly what the best practice is. So with us having some oversight, we're able to help direct them that way.
Yeah, which is why, having great medical physicist leadership is really so important.
So before we go to the other updates, I want to have a kind of open-ended question for both Eliot and Phil. So as part of my role in the accreditation committee, we do focus on things like age of equipment, updates to the software and or the hardware, changing standards, changing whatever. What recommendations might you have for some of the folks that are making application to us in terms of, and I realize it's a pretty broad question, but either from a clinical radiologist perspective, Eliot, or from a physicist perspective, Phil, what recommendations might you have? Or is age of equipment any relevant anymore, or field strength, whatever? And you kind of touched on some of that, but I think would be helpful for some clarification if you can add anything.
Well,
Yeah, so go ahead, start, please, Phil.
I think both of those parameters have some type of importance, but maybe more so on specialty exams than general exams. For example, you take CT, we can get a lot of, a large detector array, but a 16 slice unit is oftentimes a workforce of a hospital. They do a lot of the normal routine scans and they produce excellent images. So are we evaluating the images? Or are we evaluating, are they the most current, CT unit? Because we could have gone to, more slices, 64 or something along that line. And so I think on a lot of the general acquisitions, age and maybe slice thickness or a number of slices and field strength is not that important. It's just the quality of the images. But in the specialty ones, if you're doing cardiac scans, 64 slice, et cetera. And I know Eliot can speak more on that.
No, I think you bring up a really important point. One of the things that we find is a lot of these facilities have multiple CT scanners, multiple MR scanners, whether it's at a particular facility or within their network. And I know, that it's really important for the medical directors to determine which machine is appropriate for which type of study. And so a lot of sites have multiple different machines, multiple different technologists, and they have the ability to steer, some of the more challenging studies to particular systems. And so, for me, what's really important is that each site develop its own process for making that determination, and that, there's kind of there's a loop of communication. Whereas I think it's important that the radiologists and clinicians even who are, looking at the studies, be able to provide feedback back to the technologists, back to the, chief technologists and the medical directors to essentially help each site with its own process. I would love to be able to see, staff minutes or notes that, document discussions that these groups are having internally, asking themselves the question about how about the age of our equipment? How about the field strength? How about determining which types of studies should be done on what equipment? So, we only see a tiny snapshot of what's going on at these particular centers anytime we do an audit or anytime we ask these questions. But to me, the most important thing is being confident that each one of these sites has its own internal process, because it shouldn't just be the standards and accreditation committee that are looking at this. Each site's medical director should be essentially looking at this in detail and then documenting their thoughts and discussions about, what's appropriate and most appropriate for their patients. So for me, I think more than any one exam that we get submitted for review, it's the process that is documented and the documentation of a good, healthy discussion in the various networks and sites about how they are essentially asking themselves those same efficacy and patient safety and quality questions.
Great, thank you. Before we jump over to Julie, and I want to give her enough time to talk as well, just quick updates on some other areas that we're looking at. Privacy and security, clearly we want to make sure we're following all the HIPAA regulations. Peer review is more of an increased focus now in terms of that process for all of our participants. Immediate jeopardy, I want to remind folks on this webinar, you are required to report any incident under the definition of immediate jeopardy within 48 hours to us. And then we have a very similar amount of time to report that to CMS and do a follow-up audit. Phil touched on this. We are focused on MRI safety. There have been several incidents recently where a wheelchair or some other metal object has created some harm to the patient or to one of the other staff members. So we are really committed to taking a hard look at that. Direct supervision, Eliot touched on that before, and the emergency response requirements as well, in terms of what processes do our participants follow as they encounter a potential incident like that. Okay, let's save some time here for Julie. Please address our accreditation review process.
Forgot to unmute myself, sorry. So the review process, I want to discuss the accreditation process, whether you are applying for the first time or for the second, third, fourth, fifth time. The biggest thing is to always know what your current accreditation expiration date is, whether it's with us or with one of the other accrediting organizations. Per the agreement, there's timelines set up for how many days you have to submit your application, how many days we have to complete the review and present the application to the accreditation committee. But if your accreditation expiration date doesn't fit that timeline, you have to fit your timeline to it in order to make sure you get through the submission of the application and the review process before you expire. Our client services department currently notifies anybody who's accredited with us about 6 months prior to their expiration date that they should be starting a new application for reaccreditation. And I believe if you don't start the application, it will send you a reminder monthly till you do. When you apply, we've already talked about the specialty modules. That's you adding the specialty modules happens in the very beginning of the process. They can be added later on, but there's just much more to do. So it's better if you do it at the beginning and get it done during that application process. The other piece I want to remind you, in the application, either on the left-hand side or in the upper right-hand corner, there are links to the Help Center. The Help Center will provide you with the standards, will provide you with the tutorial, will provide you with the document checklist, and a variety of other videos or documents that will help you get through the application process. Now, the application review does have 3 parts: the administrative, the clinical images, and the annual physics. And just to quickly go over them, the administrative review consists of all the form questions and required documents in the application. That reviewer is going to check all of that information you've provided to make sure you meet our standards. When you do fill out your application, there is a copy feature. If this is your very first application, the copy feature won't work because you don't have anything to copy from. If you're a one-off, so to speak, and you have a previous application in the current version of the standards and the portal, then you can copy from that to the other. If you're with a large organization, that applies too, where you can copy from others in your organization. But I must stress, this is the big stress to remember, is that if you do copy, please review the information you have copied and make sure it applies to your facility and that nothing is expired and things like that, because otherwise it's going to go back to you with an RFI that you will have to fix and everything else. It just saves time if you do that quick review. The clinical images, this is all going to be dependent upon what specialties you have. If you're on the studies tab in the application, there is a link. It says view study submission requirement. If you click that link, it will open up and it will tell you exactly what studies, the number of studies and things like that that you have to submit. I'm going to remember. Oh, the other piece is that when you go to upload your studies in AMBRA, always use the link that is provided on the studies tab, either for your images or your physics. That link is a specific share link with AMBRA that allows your images to go into your personal bucket as well as be shared with us. If you log directly into AMBRA, it will not be shared with us. I tell people the first time you click on that link, bookmark it, because then you can use it for that application and any of your applications going forward, because it's based on your login and it's based on the RadSite MRN number that you can find on the studies tab. There is also, when you go to upload your images, there is a checkbox asking if you want to wrap your images. If you are a facility where your images are saved in DICOM format on a PACS machine, you will not want to check that box. If you are a, say, cardiology office who does not have a PACS machine, saves your images as JPEGs, you then do want to check that box because the JPEGs need to be wrapped in order to fool AMBRA. And then we're able to get to them, you're able to upload them and that sort of thing. Currently, images must be taken within the 6 months prior to the submission of your application. And it also must include the interpreting physician's report. The final part of the review process, of course, is the physics assessment. And Dr. Patton has talked about that quite a bit. And so you'll upload those the same as you upload your regular images and go from there. Once that application, you've completed it and you submit it to us, we review it to make sure all the pieces are there, all the images are there, the physics, the reports, and then it gets assigned to the 3 reviewers. Once the reviews are completed and sent back to us, if there are any issues, we will be sending you an RFI, a request for additional information. The admin reviewer usually takes charge of this and opens your application if they need to and things like that. But once it's fully been passed by all 3 reviewers, we then create an executive summary. It is blinded so that the accreditation committee does not know who is their judge, they're making their decision over. But they also get, in addition to the executive summary, they get the reports from the imaging reviewer as well as the physics reviewer. So they are taking a look at all the pieces before making their final decision. The AC, as I call them, meets on the 4th Tuesday of every month, and there are the 3 decisions the members can make. They can pass, they can fail, or they can issue a corrective action. Majority of them, by the time they get to the AC, our reviewers have worked well with you. So we're pretty sure most of them are going to get passed. Once the accreditation committee has made their decision, staff then works on updating the accreditation portal, our database, so that notifications can be sent out, and we create the certificates. The accreditation is a 3-year cycle unless something happens where you replace the machine and take it out of service, the facility closes, things like that. You have to notify us that way. And of course, our staff is always willing to assist you with any questions that you may have. Thanks, Mark.
Thank you, Julie. As you can see, there's a lot involved in the application process. Like Eliot's team, we have 10 folks on our accreditation committee, many of them long-serving folks, and they comprise a wide range from radiologists to technologists to administrators. So it's been a good group. I will say we don't wait always until the fourth Tuesday of the month to make recommendations. Oftentimes, if there's a timing issue, we will agree to review those applications in between. So don't worry that we have to wait till that fourth Tuesday every time. Okay, some quick updates because I know we're running out of time here on the accreditation portal and IT. Like a lot of organizations, we are particularly focused on our technology. We do have in-house IT gurus who help us work on this. So our ability to create customized portals for our larger suppliers. We have enhanced tracking and reporting now. The DICOM uploads are getting better. We are taking a look at some additional vendors there. And obviously you can get some customer support through that. I want to emphasize again what Julie ended with, which is if you have any questions at all, please do not hesitate to reach out to us. We're more than happy to help you through this process. Real quick, some highlights. This is our time for infomercial in terms of what RadSite does best, we think, and separates us from some of the other AOs. In terms of best practices, we've spent a lot of time today talking about our standards upgrades. It is a continual process, as Eliot referred to, and one we take very seriously. We think our customer support is second to none. We really do try to be very responsive to our providers out there. If we skip real quickly. Thank you. So lots of stuff on our webpage in terms of webinars, press releases, blogs, publications, etc. I encourage all of you. We record all of our webinars. You can go back at any time and review those online. Before we officially close, we've got a few minutes left. I don't know if there are any questions from folks who are on the webinar, but more than happy to have any of us try to answer those questions for you.
Yeah, one question that came up that I wasn't sure the answer to was, when does our next version, I guess Julie, is it 3.6? When will that come out and be available?
Well, I started to type a response to this. We had a staff meeting yesterday, and I know that the primary focus right now is to complete the remote scanning standards. And then once those are done, then the next big project will be finishing the 3.6. So I would say mid-summer to end summer. Does that sound right, Eliot?
That sounds right. Yep. I think approximately the process really kind of depends on what the issues are and feedback that we get from the standards committee, but I think that's a really good estimate.
Yeah.
I think one other point that I want to make sure we cover as well. We work very closely with all of the payers. I think at this point in time, there isn't a payer in the country that we don't interact with, and it's probably approaching, what, 350 payers now, Julie?
Right.
So anytime there's an issue, and those seem to be ongoing as well, maybe they didn't update their own website, whatever, we immediately jump on that. We're pretty good about resolving those payer issues before they linger too long. But obviously, what we want to pay attention to from the standards committee, from the accreditation committee, is to make sure that we are meeting the needs of the payers as well. We do have a pretty extensive review process, as Eliot alluded to, in terms of once they get through the committee, they go to our board for approval, they go to CMS for approval, and obviously we want to communicate that information as well to our payers. And so it talks about this next webinar that's coming up here, we think is one of the critical elements that's been coming to the fore lately, this whole remote scanning technology. We spoke briefly on that during this webinar, but know that that is in the process, and we'll have a webinar coming out shortly on that. Any other questions from folks in the audience or from my colleagues that we should address before we let everyone go? Okay, I'm going to turn it back over to Kristen. I want to thank Eliot, Phil, Julie. You guys have been the heart of the things that we get done here at RadSite and the reason we've been so successful. So thank you for participating today.
Yeah, thank you for your role as the head of the accreditation committee, and great job as moderator too. So really appreciate it.
Yes, RadSite would like to thank you to our moderator, Mark Casner. You beat me to it. And our presenters, Dr. Phil Patton, Dr. Eliot Siegel, and Julie Irons. If you have any additional questions, contact us at info@radsitequality.com. Just a reminder that today's webinar has been recorded and will be available through our website. If you enjoyed this presentation, be sure to check out the webinar page on our website and RadSite's YouTube channel for past webinar recordings. We hope you will join us for upcoming webinars. So this concludes our webinar, and thank you so much.